Kia ora tātou, everybody. Bruce Arrell's my name. I'm the director of the Goodfellow unit, and it's my pleasure to welcome you to this webinar tonight. We've got quite a few speakers. We've got a panel of speakers and a number of other speakers. Our first one tonight, we're going to be talking about monkeypox, and our first speaker is Massimo Giola, who's an infectious disease and sexual health physician from Tauranga. Massimo, over to you.
Thank you, Bruce. Kia ora, everyone. So I've been given the task to speak about monkeypox as a quick update. And there's lots to say, but I've been told to cover specifically these points. What will the numbers look like for Auckland and or Aotearoa? What are the possible mortality rates to give an idea to people about the seriousness of this infection? What is the clinical presentation? What are the tests to be requested? And what is the management? So I will assume people during these days and weeks have read about monkeypox. I obviously cannot cover the whole topic from top to tail. So, and also the virus and the disease is evolving. So this 2022 virus has got 50 mutations from the West African strain it descends from. So if you haven't read anything yet about monkeypox, that link leads you to an excellent summary by the European CDC. It's only about 25, 30 pages, so it's not too long. So what will the numbers look like? Very difficult to say at the present, still very early days. As you know, we have 2 imported cases so far, one on Saturday, one today. And I believe it's only a matter of days before we start seeing community transmission, as I'm sure there are already some cases probably that have crossed the borders and have not been detected yet. So this cluster, this outbreak is different from all the previous outbreaks of monkeypox out of Africa, because men who have sex with men are at highest risk. And we know from estimation my friend Peter Sexton at the University of Auckland did a few years ago, we have around 6,000 high-risk, highly sexualized MSM in New Zealand, for whom funded PrEP would be, would be provided according to the old high-risk pharma criteria for PrEP. And we think being eligible for those criteria for PrEP is probably a good marker to be at high risk of monkeypox. And in fact, some jurisdictions are starting to offer vaccination to MSM on PrEP as a surrogate marker for high risk. So potentially we have almost 6,000 possible cases. How fast they will happen and monkeypox might actually spread among them before we can launch a vaccination campaign is unknown, at a matter of very, speculative thinking, essentially. I heard some experts saying, oh, we don't need to worry because the R0 of monkeypox is below 1. So the outbreak is going to extinguish spontaneously by itself. That's not the case, I'm afraid. So the latest mathematical modeling from the London School of Tropical Medicine and Hygiene say that R0 is substantially above 1 among high-risk sexual networks. So the outbreak will continue growing and will continue growing really fast. We are up now to 9,000 cases worldwide. So what is the mortality? So if you read the textbooks, it's up to 10% with the Central African strain, which is the really nasty one, and around 1% for the West African strain, which is where this virus belongs. And most at risk for lethal outcomes are infants and young children below the age of 5, pregnant women, and immunocompromised people, essentially in Africa, people with AIDS, not on antiretrovirals. So far, with this 2022 global monkeypox outbreak, we have had 0 fatalities. But in my opinion, that is because overwhelmingly the patients are fit and healthy young men in their 30s and 40s. But the danger will be the spillover to the wider community and infection spreading to young children and pregnant women. And Aotearoa, unfortunately, has a bad record of having a faster bridging and early spillover from MSM to the wider community than most other countries. The syphilis epidemic is a very good example, because we saw the cases going up among MSM in 2011, and by 2013, we had already significant numbers among young women of reproductive age and congenital cases. And I'm happy to expand on this during the Q&A session, because it really seems to be an Aotearoa peculiarity. So the clinical presentation is atypical as well. So it's different from the classical textbook monkeypox. There is a disproportionate amount of genital lesions, suggesting direct inoculation during sex. The lesions tend to be asynchronous, whereas with monkeypox, they were supposed to be synchronous, i.e. all at the same stage. That's not the case in this outbreak. There is about 30% of people who present with the lesions without any prodromic symptoms, any fevers, any headaches, just the lesions. And they are starting to isolate monkeypox from all sorts of samples, not only the lesions, but also nasopharyngeal swabs, feces, saliva, and semen. And there are concerns that recovered people might continue shedding monkeypox virus in the semen for weeks. As we know, it's the case for Ebola and Zika, for example. So the testicles are an immunological sanctuary, which might allow for long-term viral replication even after recovery. So what tests do we need to collect? So the National Clinical Microbiology Network has given advice to take 3 swabs from 3 different skin lesions. People should use the universal transport medium swab, which most practices and most sexual health clinics will know as the herpes swab. And they also want 4 milliliters of whole blood in an EDTA tube, which is basically the blood count tube, because they want to attempt PCR from blood as well. And they want a separate bag and separate request for monkeypox samples. And obviously, as you will presumably collect sample from an unwell returned MSM from overseas, you also want to check for common STIs. So you want to do a multi-site chlamydia and gonorrhea screening, HIV and syphilis serology, and syphilis and herpes PCR using 2 more UTM swabs from skin lesions. So how will we manage? We'll have to do triage over the phone. So in all the media opportunities I have, I'm telling people if they have concerns about monkeypox, so, you know, MSM returning from overseas, developing fevers or swollen glands or a rash, they should call in advance, don't show up at the door unannounced, and people should be triaged over the phone. After that, they need to be seen in person. Unfortunately, you can't do telehealth completely, and you need to do full PPE, N95, eye protection, gown and gloves, collect the samples, inform clinical microbiology you are sending them. And then if you think monkeypox is highly unlikely, after taking history and performing an examination, just manage as you would normally do. If you have even a remote doubt monkeypox is possible, and the patient is well enough to go home, which will be the vast majority, just tell them to go home and isolate until the results are available, and inform the public health unit As you know, monkeypox has been made notifiable. So even on suspicion, public health needs to be informed. In the rather exceptional cases where patient will be too unwell to go home, presumably will be the ones with very high fevers. In that case, after informing public health, people should also speak with their local infectious disease or acute general medicine person on call to possibly arrange admission on isolation. How that will be possible with the current high occupancy rate, I'm not sure, but ideally that's what we should be aiming for. So I stayed in my 10 minutes, quite proud of myself.
Thank you very much, Massimo. That was, and well done for keeping to time. That was really interesting, actually. Okay, so our next speaker is Dr. Gary Jackson, who'll be well known to you. He's the Director of Population Health at Counties Manukau, public health physician and epidemiologist. Gary, over to you.
Thanks, Bruce. Well, my talk's about boring old COVID rather than interesting, fascinating monkeypox. But this is what's perhaps more important for us in the next few weeks. So my brief is really just to talk about what our predictions are for the next sort of 4 to 8 weeks. So I'm starting off with this slide, which you will have seen variants of. So this is just plotting the cases, the notified cases, and against a number of scenarios that have been put up. You can see the rather abrupt increase over the last 2 weeks, and that's really been put down to the BA5 variant starting to take over. So we've got a factor of two curves. You've got a BA2 curve going down and then a BA5 curve going up exponentially, and the two curves cancelled for a couple of weeks and left us with a flat or a dropping rate, but it's now starting to rise up. Okay, you'll see in this little graph as one of the advantages of running multiple scenarios at once, because we seem to be following perfectly on the scenario C2, but that's actually a bit of an accident. The scenario C2 was based on an age shift, a predicted age shift, that our older population will be getting more Omicron. It was seen as kind of a bit of a worst case scenario. But it happens to be mimicking perfectly the same thing that would happen if you had a more transmissible variant hitting the scene. So it's looking like it'll peak by the end of July, beginning of August. So we'll have over the next 6 to 8 weeks is going to be quite a reasonable COVID season for us. And similarly, this is for hospitalizations, shows the same pattern. The peak shown on this graph for the C2 scenario is a little bit higher perhaps than we might expect, because again, this is predicated on older age group, and of course older people, higher risk of being hospitalized and a higher risk of staying longer in hospital. Overall, ICU isn't the big issue really for hospitals. It's just sheer capacity and staffing, because of course all our staff live in the communities and are also getting COVID and getting flu and so on. So it's particularly the staffing that seems to be really impacting the hospital and the primary care environment. So again, the hospitalizations are going to be over the next 2 months is going to be fairly tough, but the next 4 weeks particularly so. This is just a graph from ESR. It's 2 weeks old now, so this is up to the 3rd of July, showing that BA5 was making up about 30% of the genomed PCR tests. It's not a random sample, but you can see get a fairly good idea of the exponential rise in BA5. We're probably over half the cases now are BA5 this week, given that it's a 2-week lag in cases getting the genome testing done. So that's sort of the reason for the rise. BA5's got a slightly higher immune escape than BA2, which is why it's taking over. It's possibly not intrinsically more infectious, so the R0 is possibly not that much different, except that the R effective in our population is different because it's very good at infecting other Omicron variants. So for the people who've had protection from, think they've got protection from having had an infection, that's waning quite fast. So it's a little bit hard because you're never quite sure how much case ascertainment we've got. But this is just a picture of people who've showing up as having at least 2 infections, and you can see around 3% of cases currently have already had a previous infection. So it's probably quite an important message to any of your patients that having had an infection, yes, you're protected for the first 3 or 4 weeks, you're unlikely to get it again, but after that it wanes fairly fast, and after 3 months, Omicron's ready to infect you again. So you can't just stop mask wearing and stop taking precautions once you've had an infection. Then just in the broader picture, we've got, this is Middlemore, but it's actually reasonably fitting for the whole country, really. This is taking the last 5 years, so you can see the winter peaks in 2017, 2018, and 2019. These are all fairly standard years in kind of New Zealand viral history, if you like. Influenza, a bit of RSV, and then 2000, almost nothing. Very, very flat, no influenza at all, no RSV. 2001, we opened up briefly for a period, enough to let RSV in, had the huge spike in RSV, which kind of caught up the last 2 years. But again, no influenza managed to get in before we abruptly closed the borders again, effectively abruptly closed in August. So the experience this year has been an enormous influenza spike, around 3 times a normal year. So that's where the pressure in all our practices and hospitals has been really coming from. But usefully, RSV hasn't gone like last year. So if Middlemore's any experience, we had eight isolates last week from RSV, 5 the week before. So RSV is around in the community, but it's not taking off to the same amount. I checked back, and so in 2019 we would have had 40 this week, 40 or 50 RSV isolates in a normal year. So it's very quiet. So it probably means it's just going to arrive a little bit later, and we'll get more RSV cases in August. But that's probably good that it's not peaking right at the moment. This is the same information, but just for influenza and just putting all the years together, just to really illustrate how much this year is different from all the other years. So yes, we're doing a few more viral multiplex testing, because everybody who's affected by COVID, of course, is getting the full viral samples, but it's still a stunningly different pattern in our hospitals, and as far as I can tell, it's pretty much been replicated around the country. So although the curve is coming down very nicely, and we'd love to think it just keeps on coming down at the same rate, my pick is that it's going to stabilize at around where it is and go for another 3 or 4 weeks, I expect, just given the sheer number of people who are susceptible to influenza at the moment. We're getting a reasonable uptake with the vaccine, and the vaccine's actually quite well matched for the strains that are currently seen. But with 3 years of lack of kind of immunity and reminding people's immune systems that influenza exists, it's pretty clear that it's spreading very quickly around our communities. This is just a similar illustration from the sentinel flu from Auckland, just showing the sheer rate and the speed of increase that we had, which are mirrored in the hospital isolates, and showing that South Auckland is often the first in line to get the new viruses. But I should say, actually, just back on the COVID thing, the whole country seems to be moving in sequence with the BA5 and with the increases. So it's usually, or in the past patterns have been, it starts in South Auckland, spreads to the rest of Auckland, and then there's a bit of a Mexican wave around the country. But at the moment, it seems to be pretty much going up simultaneously all around the place. If anything, the South Island's perhaps moving faster than the North Island. So it's interesting. As our borders have opened up and people are travelling much more freely, the distance is much shorter from new variants to local populations. Back to you, Bruce.
Thanks, Gary. Just one quick question. Why do you think counties have higher rates than the other DHBs?
We've got a sort of larger concentration of people living in overcrowded housing. So we've got very high Maori and Pacific populations, and we tend to live in larger households. So perfect for spreading influenza and other respiratory viruses around.
Right, right. Well, thank you very much, Gary. That's very, very sobering, your slides there. Our next section is on how to support primary care and to take the pressure off. So this will be using online telehealth and the role of pharmacy in self-care. And our first speaker is going to be Janine Bycroft, who's the GP and CEO of the wonderful Health Navigator Charitable Trust and Health Navigator.
Thanks very much, Bruce. Thank you, everybody. Look, just going to quickly run through. A lot of you will be aware of the Health Navigator website, but for those that don't, there's a lot of resources there designed by primary care to support us in doing that work, and really wanting to look at how do we shift the focus. We've had, over the last 2 years, we've had such a high focus on call if you've got any symptoms and need to be fully assessed, and we haven't really been highlighting as much about the importance of self-care. How can people manage well at home? What are the things they can do simply through pharmacy or things that they've got in their own medicine cabinet? And just making sure we've got that good safety netting information. So this is a campaign that's been running in the UK called Use the Right Service. And if you look at a lot of we have some similar diagrams in New Zealand, counties, etc., but they haven't tended to focus or include this self-care component. So we're really just wanting to encourage us all to encourage the public that there is a lot that they can do at home. And what are we doing as a system to support people to have the knowledge, the confidence, and the right resources and tools to manage safely at home and to avoid having to see general practice or emergency departments, etc. So look, I'm just going to quickly flick through some resources that you might find useful to know about, and I've got 5 tips to run through. So just a couple of things about the website that are worth knowing. It's zero-rated data. What that means is that people can access it from their mobile phones anywhere, and other than the external videos, that content is free for them. They don't need to have data on their phone. Website pages views just continue to go up and up over each year. Huge amount of content, and we work really hard to align it with health pathways and other evidence-based resources that are New Zealand based. It's been endorsed by the GP College, and last year we won a Plain English Award and a Patient Safety Award at the Primary Care Awards there. So a huge amount of plain language, health literacy, real big focus for us, and video and app libraries. So just really trying to make it easy to share with people really good resources and tools. So 5 quick tips. Number 1, I've just dashed back from the practice, and when I start my session, I open up the 3 main websites that I use every day. So Health Navigator obviously is one of them, New Zealand Formulary, and Health Pathways. You'll have your favourites, but it just is one less click if you've opened them up before you get started for the day. We've also done a bit of work to develop what we call short codes. This means you can just put hn.org.nz and / sleep, pain, stress, Kessler, cholesterol, whatever it is. That we haven't done all of them yet, but a lot of the common topics have now got those short codes. So that just makes it much quicker and easier to access that content. And also makes it much shorter if you're texting the link to patients or sending them a message through the portal. So just a quick tip there to know. There's a huge amount of self-care guides. The Turbohaler video has been really popular. Anytime I'm prescribing Symbicort, now that we're supposed to be taking people off just straight having salbutamol, make sure you show them how to use the inhaler. So that's a great video developed with ADHB. For the colds and flu for the winter season, we're reviewing a whole lot of the content to align it with Health Info, with Healthline and with Health Pathways, and just updating those at the moment, but developed a few of those short codes for those topics, and there'll be more coming. Also got a huge amount of information now in multiple languages. So and the one, so dabigatran, the anticoagulants, these are available in quite a lot of the Pacific languages, because we found this was actually a request from counties. They were having really high rates of people presenting with bleeding issues due to anticoagulants because they really just hadn't understood how they were supposed to be taking them. So those are really valuable fact sheets to know about. With the new antivirals, these are available in multiple languages as well. And the new one around Acuretic has also just been turned into a fact sheet. Also paracetamol, ibuprofen, so all the COVID type of information resources are there. The other one that's good to know about, which I haven't put on here, is empagliflozin. A huge amount of work went into developing that to make it really plain and easy to language and easy to understand, because there are some important things for people to know about. Also just developed what's called Te Kiti Hiranga. So this is an updated care planning tool and toolkit. Huge amount of resources, a lot of co-design with Maori and Pacific communities went into developing this. Quite a lot of the resources have been turned into interactive PDFs, so you can edit them online, save it and print, or people can do it at home on their own. So these are great resources in here now for your nurses to be using. It's been used right across from concussion clinics to mental health teams to long-term conditions. So yeah, real broad application, and yeah, really worth having a wee look at. These are some other great tools that save me time every day. So the paracetamol dose calculator, this is our most popular page on the website. Parents love it. It gives them quick, easy information of what dose for their child as obviously their weight changes. Also, it's got quite a few of the antibiotic calculators, but also things like the Kessler, anxiety, depression scores, etc. Interactive, calculates it for you and just makes the job for all of us that much quicker and easier. Last one, there's a whole lot of resources for clinicians, ranging from training modules. These are on a separate website, so SMS toolkit.nz, cultural safety, health coaching, behaviour change, etc. And then a whole lot of continuing professional development topics as well. So when there's great things on Goodfellow or other places, we tag those and make them available and link them into the topics. So look, always keen to hear from people if you've got ideas and things of how we can make it better. It's a real community initiative, charitable trust. Well, it's just about us all working together to develop best resources and information so that we can share them with our whānau, communities, and with each other. So we'd love to hear from you. So that's me. Back to you, Bruce.
Thank you, Janine. There was just a question there about it being available to the public. It's available to everybody, isn't
Absolutely.
it? I send patients there all the time. Our next speaker is Dr. Ruth Lard. She's the Chief Clinical Officer for the New Zealand Telehealth services, including Healthline. Ruth, over to you.
Yeah, kia ora koutou, and hey, look, I thought I'd just take a little tiki tour through who Whakarongorau are, and then finish off with the sort of stuff that we're doing. We hope to alleviate some of the burden, particularly for our primary care colleagues at the moment. So look, we're a social enterprise. Many of you will remember us as Home Care Medical. We have changed our name in the beginning of, or the middle of last year. We run the general practice after hours service, and we carry the National Telehealth Services contract. So most of our services are funded by the ministry. We've got a range of clinical teams, registered nurses, mental health nurses, paramedics, and our professional workforce is over about 1,500. In the last 6 to 12 months, we've grown that workforce with our partner centres. So we've got partner call centres, which include Ngāpuhi and Tarawa, Ngāti Whātua, as you see there. And those were specifically grown for COVID in the vaccination space, but we've also used those resources across our other services as well. We've got 16 doctors who work alongside our other clinicians, and we've got 358 clinicians which support Healthline. So these are the lines that we have available, and I'm happy to take any questions about any of those as we in the quick Q&A, but more to the point, what's happening at the moment. So you can see there that we've had a large number of contacts, 185% increase over the previous year. We've connected with over 2 million individuals. But I think it's important to recognise that we've still got pretty good call times, call answering times. I think when I had a look the other day, the longest anybody had waited over the last 2 weeks was 40 minutes, which I recognise is a really long time. But that's pretty unusual. The majority will be answered within that 10 minutes, if not 3 minutes. We have had a volume increase of around 40% over the past few weeks, and around 25% of that volume is triaged to self-care. Now that percentage actually hasn't changed with the increase in volume, and I'm uncertain really whether that means that we're triaging too many people to general practice. You'll see that we still send about 40% to a routine general practice appointments. That's if you don't get any better, then go and see sort of things quite often, or questions about blood pressure and needing follow-up. So targeting those influenza-like illnesses, I think, is going to be something which I'll talk about in the next slide. But also, I guess it's important to know that our clinicians use clinical decision support tools to help them make those triage decisions. So they're often clicking through questions, which is guiding them and also collecting information for their notes. So finally, the sort of additional activity that we're implementing at the moment to support a right care in a right place. So all of our Healthline clinicians have access to our senior nursing staff and paramedics, and they can discuss triage decisions with them. We've also got in-house doctor support, and we've used that more and more as services have come under strain. So an example of that is in the RSV epidemic last year, and in various times when EDs have been overloaded, we've pushed quite a few of our Healthline calls into that service. And there is that opportunity to use that resource more to support particularly the unenrolled patients. So people who are calling us and saying, we don't have who's your GP? And they say, well, we don't know, we don't have one. If they've got an influenza-like illness with a triage disposition of less than 12 hours, then we can look to pushing those calls through to our doctors. The other part of this is what we've called the enhanced care pathways, and that's an alteration to our pathways which enables our clinicians to guide people who are perhaps more febrile than we would ordinarily tolerate, or more breathless than we would ordinarily tolerate, to stay home with good guidance. And we've seen that work really well with RSV. And we're just in the process of training staff around that at the moment, because we recognise that the majority of these people will have an influenza-like illness. So that's a very short sort of tutu through our services, and I'll hand over to back to Bruce.
Thank you, Ruth. Stuart, Dr. Stuart Jenkins, Primary Care Clinical Director, Waitemata and Auckland District Health Board.
Thank you, Bruce. Look, I just wanted to remind people of there's a third option in terms of helping to manage demand in primary care, and that is just to very quickly remind people around the options that pharmacy offer a general practice. And so these are some of the things that, and for most of you, you probably know what we're talking about, but there's a wide range of medications that go beyond the typical over-the-counter medications that we think of. And these are the pharmacist-only medicines. And some of these are in the space in terms of supporting management of allergic rhinitis. There's an antidiarrheal, the pyramide's available. For sticky eye, they can now dispense chloramphenicol. And there's a range, quite a wide range of contraceptives available, including the combined oral contraceptives, as well as the POP, as well as the emergency contraceptive pill. So some of the other ones, there's laxatives on offer. They can also manage migraine with a short course of sumatriptan. And probably the last ones to mention that I think have got particular value is for a simple urinary tract infection. You can pop into your pharmacy and potentially get a prescription for some trimethoprim. In addition to the medications, there's a range of funded vaccinations. And again, as a reminder, they can provide COVID, MMR and influenza jabs. There's also the unfunded vaccinations, which may be quite useful to take some of your patient demand on. And they provide support around education. And then there's a range of whānau HQ services for supporting COVID management at home. So what we would suggest is that if you are wanting to look at how you can spread your demand, have a chat to your local pharmacist and just see what services and what medicines they've got on offer there, because there might be something there that will just make a difference for you this winter. So back to you, Bruce.
So our next item is a panel. We've got 5 panelists here. We've got Dr. Emma Laurie, who's an emergency physician at Auckland Hospital, Dr. Alistair Sullivan, who's the Director of Urgent Care at Tamaki Healthcare, John Cameron, who'll be well known to many of you, the former medical director of ProCare and a GP in Westmere Medical Centre, Gabriel Lord, General Manager of Practice Services and Nursing Director of ProCare, and Daniel Sai, who's a pharmacist and community pharmacy program manager at Northern Regional Health Coordination Centre. So if we can maybe each of you could just make a comment on what you've heard so far and any ideas you've got that could help deal with the load in primary care at the moment. Maybe starting with you, John.
Yeah, thanks, Bruce. I think we're all feeling the strain of what's going on in primary care, general practice at the moment. And we're all looking back at how we can actually change what we do, how we do, both to keep our patients safe as well as to keep our staff safe. Sometimes this COVID comes washing over us. I feel we're a little bit like King Canute, sitting there going, no, hold the tide back. I can push this tide back. We can't. This virus is ubiquitous. Gabriel was over in the UK shortly as I was over in the UK. COVID over there doesn't exist. They don't test for it in the community. The only testing results we're getting is from hospitals, and they're living their lives with COVID. And I'm not saying we should necessarily go to that level, but I think we need to demystify COVID within our practice teams. The safest place to be at the moment is in a general practice as far as COVID infection is concerned. We can control the environment. We can still look after our staff. It's when the nurses go off to their kid's birthday party and then they get infected there and come back. That's our risk. We also need to know who we're going to protect. Are we protecting ourselves? Are we protecting our patients? Where is our direct process going to be? I think we need to protect ourselves and our staff because that's our resource. Without that resource, we could fall over quickly. And so please keep reporting on that practice reporting tool that's out there in the Auckland general region. It's really important to know what's going on. But also being a little bit more sensible about it. I think trying to examine patients in a car or the pouring rain. No, we know enough about the COVID virus now to be able to pull back and say we can bring people into our practices safely, keeping them safe, not having a waiting room or having minimal people in a waiting room, wearing masks, all patients wear masks, all doctors wear good protection. It doesn't have to be gown and visor, a good fitting N95 mask, and good patient distancing will do that. We can continue to provide our services, but we have to do it carefully and safely. And I think we are working towards that, but we need to demystify COVID. We need to not be frightened about it as a disease. Yes, it's nasty. Some people get really sick. Some people end up in the hospital. I'm really interested in Gary's look at the intensive care rates that are going through. And that would be my marker of what's happening in our country. And that the reporting cases isn't there. Hospital admissions is sort of there, but intensive care shows the impact of the disease. I'm going to shut up now because I want to hear what you guys want to say.
Okay, so maybe hand over to Alistair, then Emma, then Gabriel, then Daniel.
Thanks, Bruce. Look, I'll keep it brief. Urgent care clinics around the country, like general practice, are absolutely under the pump. And I think it's true to say that, to paraphrase a famous politician, it's not the beginning of the end, but it's possibly the end of the beginning when it comes to both the COVID and respiratory seasonal illness. So I think what we've got to understand, of course, is that when patients come in and we see them in front of us, there's only limited things that we can do to educate them. But it's great to hear the conversations around Health Navigator. I get constantly amazed at how many patients have never heard of the National Telehealth Service, Whakarongorau. I think we've got to do our bit around pointing patients in these direction of these extra services constantly. And I think When we go out of our surgeries, what we need, and what I think we're about to hear about, is the national health promotion campaign around alternatives to walking in to see a doctor and a nurse or a nurse practitioner, which is keeping people out in the first place. And I think that's crucial as we move through the rest of the season. That's enough from me.
Great. Okay, Emma, have you got a comment you'd like to make to the audience?
So obviously the emergency departments are also really busy at the moment, but I also work at the NRHCC, and I've been working on the reinfection and testing guidance for COVID. And I think just one thing, I know it's gone out in the mid-inses, but for healthcare workers who test positive, but we do suggest that they take a second test, ideally a PCR, but if you don't have access to a PCR, you can do a second RAT test, preferably from a different batch. This is really just to ensure that certainly our workforce, if you are going to have to isolate for a more prolonged period of time, that it definitely is COVID. So we recommend that double testing strategy. If you're sick, you have to stay home anyway, and we know that, but at least you don't have that defined, prolonged isolation period. You may recover from your simple cold within a couple of days and be able to be back earlier, or your staff be back earlier. And that's it from me, unless anyone's got questions for me, so I hand on.
Okay, we've got some general questions there. If you can just have a wee look at them. Gabriel, comments from you?
Yes, so what we hear from our network is a raft of things. You know, our general practices had to rapidly change the way they did things at the beginning of COVID, so way back in 2020. And a lot of those ways of streaming and managing PPE, looking after the infectious patients, etc., have stayed. And, you know, that is creating capacity issues within general practice teams. Recently, I think in the last week or so, the NRHCC have released the latest primary care response framework, which may be of help for general practice teams. It gives really great guidance around setting up your practice, PPE. So I really would recommend general practice teams have a look at that. And of course, each individual general practice is a unique environment, and you will need to work out what will work best for you, but that's really great guidance, and I'll pop a link in the chat. That's it from me.
Great, thanks very much. Daniel, comments?
Yep, so just to add to what was mentioned by Stuart, you know, pharmacies are available and are open to accepting, you know, referrals for things like COVID care in the community. So have a chat with your local pharmacist, see what support they can provide. You know, there are a number of initiatives where we're trying to enable pharmacists to get more involved in vaccinations. So, you know, flu for the 3 to 12 years old, and in future there'll be hopefully more vaccinations available in pharmacy.
Okay, so any of the 5 panelists who are on now, any further comments from you or additional supplementary comments?
Practices might want to think about their websites and their portals as what sort of information that they've got in there, and, you know, with putting the Whakarongorau 0800 number in there might be an option. Similarly on your website, the same with Health Navigator, just with the idea that people might be able to self-care or use the telehealth service as an alternative.
Massimo, there was a comment earlier before about the monkeypox vaccine. And you may have answered it, but I think the audience may wish to hear from you on that.
Yeah, thank you. So the good news are a vaccine exists, so we don't have to wait for researchers to develop a vaccine. The 3rd generation smallpox vaccine is also protective against monkeypox. The 2 viruses are similar enough. The bad news are there is no stock. There is no stock available because there was minimal demand for smallpox vaccine. So the company was producing minimal amounts. Now they are going to scale up production, but it will take a while before there are large amounts of vaccine. Obviously, the countries are queuing up. Everyone wants now the vaccine. And the countries that have sustained community transmission obviously are at the front of the queue. New Zealand so far does not have community transmission, so we are not at the front of the queue. We heard the ministry is trying to procure some stock, but we have no idea if and when it will be available.
Great, thanks very much, Massimo. Just a question, I don't know who could take this, but are we going to get funding for flu viral vaccine infections? It really helps manage patients as we were funded for COVID. You know, I want to take that. I think the age for it's come down for kids, hasn't it? Know what the details there? Maybe somebody in the audience knows what the current and a question here, can you get melatonin over the counter without a script? I thought it required an authorized number. Anyone like to have a go at that one? I think you need a script either way, don't you? It's funded if you get the authorized number. I don't think you can buy it over the counter in New Zealand. You can in the United States. I've bought it over the counter in Los Angeles. So, yeah.
I think you can get it through a pharmacy. Daniel, you might be able to give me some more information on melatonin. I understand that you can access it through a pharmacist.
Yeah, so I'll actually double check and just respond to that query.
But I think you'll obviously have to pay for it. And I'm not sure what the cost is. It'll vary from pharmacy to pharmacy.
But you need a script though, don't you, Stuart?
I think it's a pharmacist only medicine.
Okay. It's hard to keep up with these things, isn't it? So anybody else got comments? Because we're pretty well done with all the questions here. Anybody got a final parting comment for the audience? We may even finish early tonight, which is unusual. Stuart, do you want to?
It may not necessarily have to be a question. It may be a suggestion of something that you know works well in their practice or could work well for primary care in terms of feedback. If anyone's got any clues, that would be great.
Got a couple of slightly contradictory things about melatonin there. Sounds like we need a bit of an update on that somewhere along the line. Somebody says it's prescription only, and somebody else says it's available. Circadian's available over 55 years, pharmacist only. So
yeah, I understand that's. I think that is the case. The Circadian, 2 milligrams.
Yeah. Any comment about trying to get people to wear masks again would be good. Susan Oldfield there.
Yeah, I would certainly vote for that. If you want to slow transmission, as a good public health doctor, I think it's a very straightforward thing to do in indoor venues and public transport and so on. You can see the speed of the rate of increase at the moment, and masking in schools. The other thing is just some of our infrastructure, just basic ventilation, of having clean air and reducing the amount of airborne particles that people are rebreathing is kind of a basic thing to slow these big surges down, and will really help assist with the living with it kind of approach.
And Gary, I heard from an epidemiologist in Vancouver. He was saying that if you get multiple COVID infections, it increases the risk of long COVID. Have you come across that at all?
Well, it does in that you've got each infection gives you a chance of getting long COVID. The second, third, fourth infections don't necessarily seem to give you an increased chance for infection, but it's a sort of it's a cumulative load that might be true. I saw one estimate that 2% of the UK population is currently not working because of long COVID, so it can have quite a significant economic impact as well as the health impact.
Yeah.
Sorry, I was going to answer one. I was going to talk about the RAT positive rate. The RAT positivity rate is a little bit brand dependent, and the studies, the percentage of RATs that are false positive isn't high, but as your transmission rates are lower, or as your rate in the community is lower, the percentage of those that test positive that may be false goes up. And so as the numbers were coming down, we were really trying to push that if you were going to make an important decision about a RAT positivity, that's when we were pushing the second test. As the rates in the community are going higher, a greater percentage of the positives will be true positives. I hope that makes sense. There is in the in health pathways, some sort of science behind the thinking around it. That's in the resources section under testing. If anybody wants to go on it, look, we've done some calculations to give people an idea of what the false positive and what false negatives mean.
It's that problem of low prevalence, isn't it? The false positives are always an issue. That is why screening is such a problem, because you get lots of false positives, you know.
Yeah, you need to be looking for a false positive for a specific reason, like getting a healthcare worker back to work, for instance, where it's really important to us.
So any other comments from the panel?
I just wanted to make comment about masks. So as I said to a radio interviewer during the weekend, condoms are the masks of STIs and masks are the condoms of respiratory viruses. So going forward, we should probably assume we are going to wear one or the other, probably not at the same time, probably not at the supermarket, but as appropriate to the circumstances.
I think that's one of the best lines of COVID I've heard, Massimo.
Can I just add to the monkeypox discussion? There is no health pathway at the moment, but we are working on something. So we hope to have something out in the next week or so. Well, look, I'd like to thank our panel for taking the time, and we really appreciate your expertise tonight. It's been great. So thanks again.
Everyone have a good night. Thank you, team. Much appreciated.